Good morning. So I'm Dr. Anne. I'm going to discuss the detection of congenital cardiac defect again, but here I'm going to focus on the first trimester. So why this early? So that's a question I'm going to try to answer during this talk. As you know, and as you've seen before, many cardiac defects are missed, even in the best centers. And we estimate that the detection rate is roughly 50% during pregnancy in a low-risk population. So highlighting that risk early in pregnancy can improve the screening accuracy by flagging the patient as high risk. It's also helpful in high BMIs. Oh, sorry. Psychological, well, of course, it can go both ways, and I'm going to discuss that as well in this presentation. If you see an anomaly early in pregnancy, it can also explain fetal demise early in pregnancy. And of course, it allows for an early assessment of the genetic anomalies, for example, and termination if parents wish for it. Sorry, seems to be a bit... Okay, so what is the oral detection in the first trimester? So this is an old study from 2013, where the detection rate, depending on the center, was between 2 and 50% in the first trimester. And another review from that same year found that overall the detection was 40 to 50%. Now, more recently, in tertiary care centers, we can reach roughly the same rate of 48%, if you exclude, of course, all the anomalies that would only present later. So what are the tools that we can use in the first trimester? So you probably all know about those markers that we're using to detect Down syndrome, and actually that also increase the risk of cardiac anomalies, even if the baby doesn't have any chromosomal anomaly, and I'm going to discuss that in the next slide. And then you have the direct tools that are the assessment of the heart, like we do in the second trimester, but applied to the first trimester. Okay, so I'm not going to dwell too much on this, but nuchal translucency is a very strong risk factor for cardiac defect, even stronger than the fact of having a previous baby affected by a cardiac anomaly or pre-existing maternal diabetes. And the risk would increase with the thickness of the nuchal translucency, reaching up to 20% when it's more than 5 millimeters. So generally, when the nuchal reaches 3.5, we offer a fetal echo for this pregnancy. Now, the ductus venosus, it's a structure that's easy to spot in the first trimester and that we use to estimate the risk of Down syndrome. And even if the karyotype is normal and the nuchal is normal, it also increases the risk of cardiac anomalies. Only a small proportion of fetus will have this marker. It's 1.5% according to this study, for example. But it has a positive predictive value of 5.5%. So it doesn't look like it's a very high positive predictive value, but it's much higher than the background risk. Again, same kind of marker, tricuspid regurgitation, also easy to assess in the first trimester. Similarly, a small proportion of fetuses will have tricuspid regurgitation if there is no defect, but a large proportion of babies with a cardiac defect will have tricuspid regurgitation present in the first trimester. So as a summary, if you look for those markers, a minority of patients will have it present even if they don't have a cardiac defect, but 25 to 30% of babies with a cardiac defect will have one of those markers present. So ideally, all fetus with one of those markers should be referred for a fetal echo, but of course, it depends on the center where you're in. If you have good resources, if you have a lot of people able to do those scans, and of course insurance, if parents are willing to pay for it. So more generally, we refer all babies with an increased nuchal, but for those who have intermediate nuchal or only ductus or TR anomalies, most centers actually do not refer for fetal echo, and we just start with a conventional routine scan in the second trimester. However, it's important to highlight that risk. if you see the patient in the first trimester, that will probably prompt you to push the scan a little bit further and try to look for other anomalies. And if you see the patient in the second trimester, again, look carefully for cardiac defect. So how do you look carefully now? How can we look directly for cardiac defects? So a simple marker that is often overlooked, especially in the first trimester, is to look for the situs and the axis. And the reason is that it's a much more powerful factor if you compare it to the markers like ductus, venosus, or tricuspid. You can see, like I said, it's 20 to 30% of babies with cardiac anomalies who have a marker present, but up to 80% will have an abnormal axis, so that's easier to spot. Now, the translucent trachea view, again, it's something that's quite easy to do in the first trimester if the baby's in the right position. And if you add this to the axis and the nuchal translucency, you can reach a detection rate of up to 90%. Of course, that would only include the cases that are amenable to early diagnosis, the major cardiac defects, basically. However, it comes at a cost of a high false positive risk, and I will discuss that later as well. And then the four-chamber view that you can also do in the first trimester, and that would increase the accuracy to up to 90% according to this study. Now, how can we absorb all this in a routine first trimester scan? So that's a group that actually looked in all first trimester scans, and that they were trying to find out what was associated with a high detection rate. And actually, the centers that were using a systematic anatomical protocol were doing much better than the ones that had no protocol, and the anomaly was just spotted by chance, basically. And that same group very recently published another study where actually they said that, yes, there is a 55% detection rate. Like I've quoted before, it's always around 50%, but that's much improved if you go systematically for the four-chamber view, add color flow, and look for the outflow tract. But what are we required to do? Actually, in the first trimester, and again, I'm just talking about the first trimester here, the only thing that we're supposed to do, at least until now, because apparently they're producing new guidelines, but we should only be looking for the heart rhythm. Now, in the US, they have other guidelines, but this is only for high-risk patients, and this is only something that you may be doing, but you are not required to do, so it's not mandatory. But if you look in detail in who they deem high risk, it's actually almost everybody, because if you're 35 years or older, if you have diabetes, IVF, multiple gestation, BMI of 30 or more, it's a lot of patients actually in Dubai. Now, like I said, it's not mandatory. It's just a guideline that you can use, but you don't have to apply it to all pregnancies. Now, is it only feasible? So that's also a nice study that has looked into how often you could get those views in a routine clinic. So, and if you systematically look for four-chamber and three-vessels trachea view, you can achieve those views in 80% of the case. So basically, it will never be 100%. So because there will always be false negative, and I'm going to discuss this, and false positive, and I will also discuss that later. So what are those false negative? Well, there are quite obvious technical difficulties in the first trimester because of high BMIs, or just because the baby is only 11 weeks and too small to be properly assessed. And of course, medical limitation like the progression of disease, and the other talks were a little bit more focused on that. So as you know, the heart is extremely small at 12 weeks. Now, this is a very interesting study that was published recently, and they've actually, they had a very detailed protocol in the first trimester. Every patient, low or high risk, had a scan with four-chamber view, three-vessels trachea view, axis and situs. And in those two groups, if you exclude all the anomalies that are not detectable in the first trimester, you can see that in the low-risk group, they achieved a detection of 50%, like we quoted before. But in the high-risk group, it was up to 97.7%. And interestingly, they had no false positive. And actually, they've looked into those cases that were missed. And it was very often because of human or technical error. So what is an error is when you don't put too much time and effort in getting the right view, the right angle, the right color bleeds through the septum, and you accept the view. And of course, maternal obesity of multiple pregnancies. But that means that we can achieve a very high rate if we want it. But of course, that means needing to extend the time and the effort you put in your scan, which is not always possible, of course. Now the false positive. So like I said, in some studies, we have up to 12% of babies who will have an abnormal 4-chamber or 3-vessel trachea view or increased nuchal, and up to 8% with another of those Down syndrome markers. So how to deal with the consequences for the parents? Now we know that actually, interestingly, at the start of pregnancy, all parents, or the vast majority of parents, want an early diagnosis. So they would go for a detailed scan in the first trimester. And actually, it's also been shown that when the scan is reassuring, it's very beneficial in terms of psychological well-being for the parents. Now, of course, when they are markers, it's difficult for them to deal with the uncertainty. But it has been shown that parents feel actually better if the doctors acknowledge this difficulty and helps them to deal with it. And also this increased anxiety that you see in the first trimester would actually disappear after the 20-week scan if everything is normal. And if the parents that have not been flagged in the first trimester and are only diagnosed with an anomaly in the second trimester, actually they said that they would have preferred to have a heads up, or at least come prepared to the scan. And you can think that you cancel them before the scan, but they don't listen to you. They just think the baby is perfect. So if you flag them in the first trimester, at least they will have a clue. So we can assume that it seems to be beneficial, but it's still very important to support the parents, of course. Now, not everybody agrees. This was a very recent debate in the International Society for Prenatal Diagnosis, and there were pros and cons. Now, there was a small majority of pros for an early anatomic scan, and the cons were mainly about availability of training, anxiety levels, and yeah. So what should you be doing? So there are some expert opinions from the ESUAG, for example, that we should at least try, because it's not mandatory at the moment. So we should try to train your eyes to see those 4 chambers and 3-vessel trachea view. This was presented last month in Abu Dhabi, how to improve your skills. Basically, keep it simple at the beginning, but be systematic, master your equipment. You can also develop new clues. The cardiologists are actually very good at recognizing patterns, but we're not as good as them in obstetrics. But we can train your eyes to do it in the first trimester and become better. And so if you're very simple in screening, you'll be able to be very thorough when it's needed. So in conclusion, we know it's difficult. Even in tertiary care centers, we're missing those cases. And early detection seems to be beneficial for all. It has the potential to improve the detection by highlighting a risk early in pregnancy. Ideally, everybody should be referred. Now we know that it's not always possible. And also there is a drawback, it's that it has a high rate of false positive that we need to deal with. But this can only be improved by being trained and by developing communication skills for parents. And that was it.